So, Dr. Sharmin Apu, this is your station. Please read out the
Good
question.
evening, Dr. Rifat.
Hi, how are you?
I'm fine, doctor. How are you?
I'm doing fine. So, just read out the question.
Okay. So, 34-year-old builder falls from a height 12 feet on the to the
Pavement. Pavement.
pavement. Okay. Along with the bilateral refracture, he is discovered that he have a fracture of the scapula of the neck. The image on the following page is the distal aspect of the scapula, demonstrating the normal anatomy.
Okay. Could you tell me which is the portion? This one.
This is the acromion of the scapula.
Could you tell me what is C? Number C.
Is the coracoid process of the scapula.
Okay, doctor. Could you tell me what are the muscles that are attached with the coracoid process?
Yes, there are three muscles. One muscle, the insertion of the pectoralis major, there will be coracobrachialis and the short
Is it pectoralis major?
insertion of the pectoralis minor. Sorry, insertion of the pectoralis minor and origin of two muscles, that short head of the biceps brachii, another is that coracobrachialis.
Coracobrachialis. So, what is number B?
Number B is the supraspinous fossa.
Okay, that's great. What is number F?
Is the lateral border of the scapula.
Is it?
Oh, sorry, this is the no side. This is infraspinous fossa.
Okay. What is number A?
This is the spine of the scapula.
Okay. What is number E?
Is the glenoid cavity of the scapula.
Okay. Could you tell me which muscle is attached with the infragluteal tubercle?
Long head of the triceps brachii.
And which one is attached with the supragluteal tubercle?
That will be the long head of biceps brachii.
Okay. So could you tell me what are the rotator cuff muscle?
Yes, there are four muscles. The supraspinatus, infraspinatus, teres minor, and the subscapularis.
Okay, tell me why shoulder joint is not stable?
Because the shallow glenoid cavity and the lax capsules and a few ligaments, and there is lower portion is not supported due to the quadrangular space.
Okay. Could you tell me the insertion of the rotator cuff muscle and their nerve supply and their function one by one?
Yes. Supraspinatus, infraspinatus, and that teres minor. They are. Should I mention the origin also?
Not. You can. Okay, you can. These are important. You can.
Okay, the supraspinatus will take origin from the supraspinous fossa of the scapula, and the infraspinous, which will infraspinatus muscle, which will take origin from the infraspinous fossa, and the teres minor, which will take origin from the lateral border of the scapula, dorsal lateral border of the scapula, and these three muscle will insert it into greater tuberosity of the humerus. And another one is that subscapularis, which will originated from the subscapular fossa of the scapula, and it will take insertion in the lesser tuberosity of the humerus. And the nerve supply of the subscapularis is upper and lower subscapular nerve, and the supraspinatus and infraspinatus is supplied by the subscapular suprascapular nerve, and the teres minor, it will be supplied by the axillary nerve.
Tell me from where the suprascapular nerve originates from?
Suprascapular nerve is coming from the root of the brachial plexus.
Upper trunk of the brachial plexus. Okay.
Upper trunk, sorry, upper trunk of the brachial plexus. Yes.
Okay. Would you tell me which muscle is attached with the number 6?
Number 6. This is the ventral surface and the lateral border, right?
Okay, this is a lateral border.
So there will be origin of the teres minor muscle.
Okay, come to this picture. Could you tell me which bone is this?
This is the clavicle,
Yeah,
left clavicle.
this side, left, right. So, what are the identifying point regarding the left-sided clavicle?
Yes. So medial end of the clavicle will be rounded, and that lateral end of the clavicle will be flat and quadrangular. And there is a superior. There will be one costoclavicular impression for the costoclavicular ligament in near the head, and there is a surface, inferior surface. So this inferior surface actually containing the subclavian groove.
So, these are the most important thing.
The head and the medial one third will be concave, right?
So, this one is the medial one, right?
Yes, yes,
The lateral one, that is a flat and that is rounded.
convex. Yes,
It's
and we can see this is left clavicle because we can see the inferior surface here, right?
so medial portion is the convex to the front, right?
Convex, yes.
This portion is the concave, right? So don't forget this one
I'm
because
sorry, yes.
it's in the exam several times in the. So, okay, now come to the brachial plexus. So could you tell me what is number 17? This one? Can you see me, doctor? Hello?
Uh,
Hello?
yeah, I can see you.
Who is this? I-
Hello, I'm sorry, I got
is it
call
Jane? Dr. Jane?
Yeah, yeah.
I will come to you very soon.
Yeah. Sorry,
But
sorry. Because there was no one talking, I spoke. That's
it's okay. It's okay. So, guys who wish to join in the mock, and I have already told you that practicing is the main key. So just don't hesitate to join. Just raise your hand, and it's a very homey environment. I will just discuss, and if you can't answer, nothing to worry about. We'll uh, cover everything, no problem. Just it's a homey environment. Just uh, remove all of your fears, nothing to worry about. We are here to just only for practicing purpose. So guys, raise your hand. I'll come back to you. So Dr. Sharmin, are you there? Hello, Dr.
Yes,
Sharmin.
yes, sir. Yes, I'm here.
Okay, please, let's continue. What is number 17?
Number 17, the picture is not clear to me. Number 17 is the median nerve.
Okay, it's okay. What is number 18?
Number 18 is the musculocutaneous nerve.
Okay, could you tell me the condition of the musculocutaneous nerve? What becomes it in the forearm?
It will be that lateral cutaneous nerve of the forearm.
Okay, so what are the muscles that supply the musculocutaneous nerve in the arm? Would you please increase your voice? We can hear you properly.
Oh, you cannot hear me?
Okay, louder, please.
Yes,
Like,
yes.
what are the nerve supply of the muscle that supplies the musculocutaneous nerve?
Yeah, there are three muscles that biceps brachii, coracobrachialis, and that brachialis, biceps brachii, and the coracobrachialis.
Okay, could you tell me the root value of the musculocutaneous nerve?
Is the root value is like 5, cervical 5 and 6
5, 6,
and
and
7,
5, 6.
3. Yes, 5, 6,
Okay,
and 7.
so could you tell me the structural relationship of the brachial plexus in the neck, like root, trunk, division, and the cords?
Yes, yes. So if that root, it will exit from the intervertebral foramen and it will passes in between two muscles, that is scalenus anterior and scalenus medius muscle. And after that, the trunk will crosses in the posterior triangle, and it will be like two trunk, like upper and lower. It will be like in relation with the subclavian artery.
Hello.
The lower trunk, it will be in behind the first rib,
Hello, sound is not
Sound
clear.
শোনা যাচ্ছে না
Exactly.
রিফাত
Mr. Could
ডক্টর
you,
রিফাত
yes, yes. Could you
শুনতে
please,
পাচ্ছি না ভাই
could you please increase your sound, Dr. Sharmin, please? We can't hear you properly.
Really? I'm sorry about that.
No, no problem. Just try to
Can you hear me?
slightly, slightly louder, please.
Oh, I think I should rejoin Dr. Rifat.
Okay, just disconnect and rejoin. Again, we'll come back to you. Is there Dr. Jane? Are you there, sister?
Yeah, I'm here.
Loud and clear. So could you tell me the root value of the muscle? Okay, just continue the question I asked Dr. Sharmin, the structure relation of the brachial plexus, different structure.
Okay. So the root will start from the intervertebral foramen, and it will pass between scalenus anterior and scalenus medius. Then comes the trunk. Trunk will be related to the subclavian artery. So upper and middle trunk will be superior to subclavian artery. Posterior, lower trunk is posterior to the subclavian artery near the first rib. After that, divisions.
Okay.
Divisions will be related to the middle third of the clavicle, and followed by cords. Co-
Is it in the axilla and cords related? Which vessel? Could you tell me?
cords are related to second part of axillary artery,
Excellent, excellent.
and yeah, that accordingly they will be posterior, anterior, and lateral.
Okay.
Sorry, posterior, middle. That.
Could you tell me which nerve is this?
Which one? That is.
Is it number 626?
Yes, that will be ulnar nerve.
Ulnar nerve, right. Could you tell me the root value of the ulnar nerve?
C8, T1, and C7. Sorry.
Is it? Is it? It's C8 and T1, right? C8,
Yeah.
not C7. Could you tell me about the ulnar paradox? What is ulnar paradox?
So if there is an injury near the elbow, there will be less clawing of the hand compared to when the injury is near the wrist. So that is the ulnar paradox. That is because there is when there is injury near the elbow, there is also deficiency in the movement of the flexor digitorum superficialis, and that is why the clawing is less. Whereas when the injury happens near the wrist, because of the exaggerated working of the flexor digitorum profundus, there'll be less, there'll be more clawing.
Okay, is there anyone who can explain the ulnar paradox here? Is there anyone? Okay.
Hello.
Okay, Dr. Riaz.
Yeah, because I think because of intake of FDP muscle, FDP. In case of injury in the wrist, injured intrinsic muscle of the hand, and escape the FDP muscle, flexor digitorum profundus muscle. For that region, action of the flexor digitorum muscle is it is attached distal phalanx of the fifth and fourth finger. When it is intact, more flexion.
Okay, medial portion of the flexor digitorum superficial is supplied with the
By ulnar nerve.
Ulnar nerve.
Which division of the ulnar nerve? Okay, let it go. Okay, could you tell me ulnar nerve supply of the ulnar nerve in the hand?
Yeah. So it supplies dorsal and palmar interossei. It supplies adductor.
All the muscles except of muscle, right? So
Yeah.
is supplied with which nerve?
So loaf muscles are supplied by median nerve.
Okay, that's great. Okay,
So
could you tell me which is number 21?
Number 21. That is posterior cord, so that is radial nerve.
Okay, radial nerve. Could you tell me the root value of the radial nerve?
It's C5, C6, C7, C8, T1.
Okay, C5 to T1. Very good. Okay, doctor, could you identify this muscle?
Deltoid.
Deltoid. Could you tell me the origin of the deltoid?
So the deltoid originates from the spine of the scapula and then lateral third of the clavicle.
Okay, and insertion of the deltoid?
Deltoid tuberosity of the humerus.
Okay, and the function of the deltoid?
So
Individually, the fiber of the deltoid.
individually. Okay. So anterior head of the deltoid helps in flexing of the arm. Posterior part of the deltoid helps in extending of the arm. And all together work in abduction of the arm from 15 to 90 degrees.
Okay, so any associated function like anterior fiber also the flexion and medial rotation, and posterior fiber also does the extension. Right. So what is
And
the
lateral.
nerve supply of the axillary nerve?
For the deltoid, it's axillary now.
Could you tell the root value of the axillary nerve?
C5, C6, C7.
Okay, that's great. Okay, doctor, could you tell me about triangular space of the shoulder? Triangular space of the shoulder?
Triangular space is this one. Yes, that is triangular space. So that is formed by teres minor superiorly, inferiorly teres major, and laterally it is longate of triceps. It contains subscapular vessels.
Circumflex scapular artery, right? Circumflex scapular artery.
Okay, sorry.
Okay, so what about the triangular space?
So the triangular, this is triangular interval and
quadrangular space.
yeah, quadrangular space is formed by teres minor. Then there is teres major, superiorly, inferiorly. Then there is longate of triceps and humerus. That contains posterior circumflex vessels and axillary nerve.
Exactly, and humeral artery also. Right.
Yes.
Could you tell me the branches of the subclavian artery?
Subclavian artery. Yes. It has vitamin D/C. V is vertebral artery. T is thyrocervical trunk. Then there is internal thoracic artery, costocervical trunk, and then there's dorsal scapular artery.
Okay, so tell me the which muscle divides the axillary artery and how many parts? And could you tell me the branches of the axillary artery?
Yeah, so axillary artery is divided into 3 parts by pectoralis minor.
Okay, and
First, second, and third. So, so first part of axillary artery has one branch, that is thoracoacromial artery, and second part has 2 branches, lateral thoracic and
is it the first branch?
uh, first branch is thoracoacromial.
Is it? Is there anyone who can help?
I'm getting confused. Yeah, please, somebody else.
Suprascapular.
I'll tell.
Suprascapular.
Okay, Dr.
Sorry, superior thoracic.
Exactly, superior thoracic artery.
Superior thoracic artery first part, second part superior thoracic. Second part থেকে আসবে দুইটা artery.
Two vessels, right?
Hello. হ্যাঁ, thoracoacromial and thoracoacromial and subscapularis.
Lateral thoracic.
Sorry, lateral thoracic and হচ্ছে thoracoacromial. And from third part to subscapularis and anterior posterior humeral sarcophagus humerus artery. anteroposterior humeral circumflex.
Okay, that means before the pectoralis minor, first part gives origins to the superior thoracic artery, and behind the pectoralis minor, second part gives origins to the thoracoacromion and atothoracic artery, and third part gives the subscapular and anterior circumflex and posterior circumflex humeral artery. Right? Did you get it, Dr. Jane? Hello.
Yes, Dr. Fat, got it.
Okay.
Thank
Okay.
you.
No problem, sister. Okay. Now, could you tell me which type of picture is this?
This is a coronal cut in the MRI of shoulder joint.
Okay, this is a coronal oblique MR arthrogram, right? So could you tell me what is number 8?
Head of humerus.
Head of humerus. What is number 10?
Supraspinatus tendon.
So what is the function of the supraspinatus?
It helps in abduction of the arm up to 15 degrees.
So which muscle initiates the abduction of the arm?
Supraspinatus initiates
So
0 to 15. Yes, sir.
So what is number 5?
Deltoid.
So what is number 1?
Acromion process.
Okay, again the same question because it's very important. What are the okay, what is number 4? What is number 4?
Clavicle.
Okay, what is number 7?
7 is glenoid cavity or glenoid labrum.
Okay, and this one the glenoid labrum, right?
Yes, sir.
What is number 3? This one is the
I've forgotten the name. It's infraglenoid.
okay, no problem.
Axillary ridge.
Which one? Axillary recess, right? Axillary recess.
Number 3.
Okay. Got it.
Tell me which muscle is this?
Pectoralis major.
Could you tell me the origin of the pectoralis major?
Yeah, it originates from the medial third of the clavicle and upper 6 ribs and sternal border, lateral border of the sternum.
External oblique aponeurosis also. Basically, it has 2 origin from 2 sides. Could you tell me?
Yes,
It's very much important.
So there's clavicle part that is from the medial third of the clavicle. Then there's sternal part.
Okay. So details more about sternocostal head.
Yes, sir.
Okay, it has 2 parts basically. One is clavicular head and another one is sternocostal head. Clavicular head originates from the medial half of the anterior surface of the clavicle, this portion basically. And
Yes,
this
sir.
portion is the sternal head, anterior surface of the sternum, and upper 6 costal cartilage, and also external oblique aponeurosis. This one is the external oblique aponeurosis. So this the whole is pectoralis major. So could
This origin. Okay.
you tell me where it get inserted?
So it gets inserted into lateral lip of the bicipital groove.
Okay, that's great. Could you tell me what is the function of the pectoralis major?
Pectoralis major helps in flexion of the arm and medial rotation of the arm.
Okay, so could you tell me the which muscle is number 13?
Serratus anterior.
Okay, don't say the answer like you are asking a question. Just
Okay, sorry, serratus, and this is serratus anterior muscle.
very much fluent, and definitely will pass in the exam because you are very much fluent, and just continue up to your exam. So when is your exam?
Yes, sir. So I've applied for Pune. Actually, I've paid for Pune.
Okay, no problem. That's why I think your exam is very near, right?
Yes, sir. Yeah.
So
February.
February.
Yeah, February.
Could you tell me the insertion of the serratus anterior?
Insertion. Yeah, it inserts into the medial border of the scapula.
Exactly, ventral medial border of the ventral. Basically, scapula is here and ventral, and uh, uh, that pushes the scapula with the posterior portion of the thoracic wall. So what happens when long thoracic nerve is injured?
So there is winging of scapula because the serratus anterior doesn't function, and whenever the person abducts the arm, there is winging.
Okay,
So it does not pull it to the thoracic wall.
you tell me the root value of the long thoracic nerve?
C5, C6, C7.
Very good, excellent. So I think we have covered almost all the questions from the shoulder. Now come to this portion. You have 1 minute to read out the question. Please continue.
A 50-year-old patient requires cannulation of the cubital vein. The colleague who carried it out calls you soon after. He's concerned that he may have inadvertently cannulated an artery instead of a vein. This is a dissection of the left cubital fossa.
Okay. So, doctor, could you tell me what is number A?
A tendon artery. No, that is median nerve.
Exactly. Which sided? Right or left? Guys who wants to join,
right side.
Please raise your hand, because we have so many stations to practice, and without practicing it's really difficult to pass. Just raise your hand. So it is left sided, right? You have already mentioned this picture.
Yeah, it is written left fossa. Yeah.
So could you tell me what is number B?
B, right side. It's flexor origin. So flexor carpis, flexor digitorum superficialis.
Is it?
No, I'm not very sure of cubital fossa. I think someone else should do this. I'm very confused.
Is there anyone who can answer?
Coronary.
Exactly.
Coronary.
Right. So could you tell me about C? What is number C? This one.
Radial artery.
Sorry?
Radial artery.
Is it?
No, medial side, ulnar artery.
Enters into the forearm. So it
goes deep.
And so what about the number H, doctor?
That is lateral, so radial artery. Okay.
Exactly. So could you tell me about number D?
D is cephalic vein.
Exactly. So cephalic vein lies laterally. And what about, it is not marked here, there is also another vein. So what is this?
Basilic vein.
So what about number F?
That is biceps tendon.
Okay. Could you tell me more about the biceps tendon, where it originates?
So biceps, the long head of biceps originates from supraglenoid tubercle, and short head of biceps from the coracoid process. And the biceps tendon inserts into the radial in the tuberosity in the radial, near the radial head, radial tuberosity.
Is the head is situated in the head? Is there tuberosity situated in the head?
No, it's below the head. Sorry, radial tuberosity of the radius bone.
So could you tell me the nerve supply of the biceps brachii?
It is supplied by musculocutaneous nerve.
And the function of the biceps?
Flexion of the arm.
And the most important.
And flexion of the arm
and anyone?
Flexion of elbow.
Supination.
Oh, sorry, flexion of elbow.
Important function of the biceps brachii, right? Don't forget This function because your examiner will ask by just saying what is. So
flexion of elbow and second function is, sir? I'm so sorry. I'm
Supination of the forearm.
okay.
What?
Supination of the forearm. Okay.
Okay. Could you tell me about number G?
That is brachioradialis.
Exactly. That's great. So is there anyone who wants to join in the mock? Dr. Riaz, Dr. Jain, just keep in touch.
Yeah,
Yeah,
I'm
I'm here.
Come back to you very soon. Isn't there anyone who wants to join in the mock? Guys, I always would request you to join in the mock because until and unless you just start your practicing, it will be really difficult to pass in the exam. Dr. Kaushik and Dr. Tanvi, everyone, just practice, just practice and practice. I'm here to help you. Okay, Dr. Riaz Bhaiya, could you tell me which bone is this? Number A.
this is humerus,
Okay, could you tell me more?
upper part of humerus,
Which sided? Which side?
right-sided.
Okay, could you tell me the identifying point of the humerus? Why you said it is right-sided?
Because of there is a head of the humerus which is directed medially, and there is tuberosity, greater tuberosity and lesser tuberosity, and there is an intertubercular sulcus which lies post laterally.
Okay, is it tuberosity or tubercle?
Tubercle.
Okay, that's good. So head is directed upward, backward, and medially, and there is a bicipital groove, and there is a greater tubercle and lesser tubercle, right? So could you tell me?
Right.
Could you tell me what is number 3?
This is greater tubercle.
Okay, what is number 8?
Lesser tubercle.
Okay, you tell me what is number 6?
This is intertubercular sulcus.
Or groove?
Bicipital grooves.
Okay, so what are the attachment in the bicipital groove?
In lateral lip, pectoralis major insertion, and in medial lip, tetralis major insertion, and in the floor of the bicipital grooves, latissimus dorsi muscle inserted.
Okay, that's meant lady in between two.
Two between major, two major, lady between two major.
So, could you tell me what is number
Dr.
10?
Rifat, your sound is slightly slow.
Okay, what is number 10, doctor?
And this is anatomical, sorry, this is surgical neck.
Okay, so would you tell me the importance of the surgical neck of the humerus?
In here, axillary nerve and anterior posterior circumflex humeral artery anastomosis.
Okay, could you tell me what is this?
This is lower end of humerus.
Which sided? Which sided, doctor?
Right or left? This is right side, right side.
So why do you tell me this is from the right side?
Because there is medial epicondyle and lateral epicondyle here, number 5, and there is a trochlea.
Okay, which one is trochlea?
Number 13.
Okay.
And there is number 3.
Number 10.
This is number.
What is number
10? 10 fossa for olecranon process.
Number 10 is olecranon fossa, right?
Right.
Could you tell me what is number 3?
Coronate fossa.
So you are having 3 bones in front of you. One is humerus, and one is ulna, and one is radius. Are you able to articulate these bones?
Yes. With the capitulum articulates with head of the radius, and with trochlea articulates with the trochlear process of the ulna, and olecranon process with articulars with the olecranon fossa of the humerus.
Okay, doctor, could you tell me what is number 9? What is number 9?
Ulnar tuberosity.
Is it?
Sorry.
Is it?
No.
Is there anyone who wants to help?
It is the articular surface for the radial head.
Exactly, that is the radial notch. Could you
Radial notch.
tell me which structure articulates or holds the head of the radius with the
Radial tuberosity.
No. I would like to ask the same question again. Which structure holds the head of the radius with the ulnar hair?
Annual ligaments.
Ulnar ligament.
The examiner would really ask you this question because it's very favorite for them, though it is not given in our book, right? So,
Right.
could you tell me what is this number 6?
Olecranon process.
That is olecranon, right? Or olecranon. So, could you tell me which structure inserts in this portion?
In brachialis muscle.
Triceps.
Triceps.
Right, triceps. Don't forget this one because we are very much concerned with the triceps muscle, but we are not aware of with the insertion of the triceps, right? So could you tell me what is number 11?
This is radial tuberosity.
Okay, radial tuberosity. Could you tell me which sided radius this one?
This one is right-sided. A right-sided.
Why?
B
one
because
single identifying point.
Because ulnar tuberosity lies medially.
Okay, this is the ulnar tuberosity lies medially, and number 2 is another most important, that is anterior oblique line of the radius that lies anteriorly, right? These 2 portions.
Right.
We'll ask. Okay, could you tell me which is this and what do you see in this X-ray?
This is X of elbow
And
lateral view and showing displacement in the distal part of humerus, which indicating
until unless you mention about the fracture of the humerus, it is incomplete.
Supracondylar fracture of the lower part of humerus.
Supracondylar always lies in the lower portion, right?
Right.
You need to mention the lower portion. So it's a supracondylar fracture of the humerus, right? So what are the associated injuries that may occur in the fracture of the supracondylar fracture?
In case of supracondylar fracture, there's may be injured ulnar nerve, ulnar artery, median nerve, and in case complete fracture may injure radial nerve also.
Okay, what will happen after injury to the ulnar nerve?
In case of ulnar nerve injury, there will be deficient in both motor and sensory, the lower part of this fracture.
In one sentence, that is a claw hand, right? So what
will
happen after the injury of the radial nerve?
Wrist drop
and
finger drops and loss of sensation in the past OIV space.
Okay, that's great. Okay, so this is the articulation, and you have already mentioned this portion. Okay, so what is, can you see this picture, doctor?
Yes.
Okay, so okay, before going to the picture, just tell me one thing. What are the what are the muscles that supplies the musculocutaneous nerve? Because it will ask you in the question again and again.
Okay, cocobrachialis, biceps brachii, and brachialis muscle are supplied by musculocutaneous nerve.
Okay, that's great. So that means biceps brachialis and coracobrachialis, right?
Yes.
Okay, so come to this picture. Could you tell me which structure is this? Number 10.
Number 10, extensor flexor carpi radialis.
Is it, doctor?
And
Guys, you will have to very much habitual with the cadaveric pictures or dissection, because ask you any
This
they
is
all
flexor carpi ulnaris.
Flexor carpi ulnaris.
exactly.
FDS.
So that is flexor digitorum superficialis. Number 10 is the flexor digitorum superficialis.
Okay. Flexor
Maybe
digitorum superficialis.
remember, in your real exam, you will be only asked the uh, dissection or the cadaveric pictures, and they will ask all the associated questions with the cadaveric pictures. Other than if there is no picture of any muscle, they won't ask you anything regarding that muscle. Remember, so always keep in mind.
This picture, how we will understand this is flexor digitorum superficialis?
So, so what is this? Tell me, what is this?
Pronototeris, I think. Which one? Number 7?
7.
Medial
Medial
epicondyle.
epicondyle.
Yeah, medial epicondyle. Okay.
This
Then?
portion is the medial epicondyle, and this is the common flexor origin. So these are the all the muscles that originates from the superficial muscles that originates from the medial epicondyle. And the most medial muscle that lies in this portion is the flexor digitorum superficialis. So could you tell me what is number 9?
Number 9 is pronototeris.
Okay, pronototeris had 2 head, and so number 9 is which head?
Medial head.
Humal head, right? So we have gone through this picture before. Could you tell me what is number 3?
Number 3, bicipital tendons.
So isn't there any participant, Dr. Tanvir Bhai, Dr. Kaushik Howladar, please raise your hand, and all the doctors, Dr. Bubli or something else who wish to join, please raise your hand. I will come back to you. So, could you tell me uh, regarding this picture, what is number 13?
Extensor digitorum.
Is it extensor digitorum?
the retinaculum.
Sorry, extensor retinaculum.
Extensor retinaculum. Could you tell me what is flexor retinaculum? What is flexor retinaculum?
We are not able to hear you, Dr. Rifat.
Can't you hear me, doctor? Can't you hear me?
Yeah, now better.
Okay. So I do have some network issue. Just wait for a while. I am okay. Can you hear me right now?
Right.
Okay. So could you tell me what is number 23?
Number 23.
Yes.
This is ulnar artery.
And number 25?
25. Please mark it. I don't see.
Ulnar. Can't you see, doctor?
This is ulnar nerve.
Okay. Is it correctly arranged, doctor? Is it
No,
correct?
no. Correctly not arranged because ulnar in usually ulnar nerve lies medially, but here ulnar nerve lies laterally.
That's great.
In case of cadaveric.
Okay. We have
No,
so
this is median nerve, no?
no. Why would it?
No. Ulnar nerve and ulnar artery.
So tell me, which one is the medial nerve? Is it I think medial nerve.
Marking is
Median
not
nerve
clearly visible.
So why it is medial nerve basically?
6,
16.
median nerve 6,
16.
16 or the 16.
16. Yes.
Exactly.
They are the thinner muscle.
This
Yes.
This is one of the medial nerve.
this is median nerve.
Is the median nerve, right? So this is the ulnar nerve, and ulnar nerve supposed to be lies lateral to the ulnar artery. So this picture is incorrect. Anatomically, the nerve will lie in the medial
Medially.
ulnar artery, to the lateral to the ulnar nerve. So, guys, did you get it? Because it's very important, and in your real exam they will really ask you regarding this picture. If you do have hand in your exam and this academic picture is incorrectly given in the picture, but they would ask you. So could you tell me what is number 2?
Lister tubercle.
No, this portion,
Sorry.
this one. Can you see, doctor?
Thinner muscle.
Thinner muscle comprises so many muscles, so specifically
Flexor pollicis brevis.
is it doctor? Is there anyone who is to
Abductor pollicis brevis.
Abductor pollicis brevis.
Exactly. So could you tell me what is number 1? What is number 1? Dr. Riaz, are you there?
Number 1.
Yes, number 1.
Hypothenor muscle.
Adductor digiti minimi.
You'll have to answer.
Adductor digiti.
You'll have to answer thinner and hypothenar muscle individually, right? Don't say hypothenar or hyperthenar. What or thinner muscle like this way. Just answer mark the name of the muscle correctly individually, right? So this
Right.
Abductor digiti minimi. So could you tell me what is number 8?
Number 8.
This one.
This is flexor carpi radialis.
And what is number 9?
Longus.
No.
Radialis. Number flexor carpi ulnaris.
This
Yes,
one is
correct.
Long.
this. There is no flexor carpi. Which
Longus.
radialis? No radius longus. No. This one is the only flexor carpi radius, right? Is there any longus?
No, flexor carpi radialis. That's one.
Flexor carpi radialis, flexor carpi ulnaris. The right side.
No longus, right?
Number 3 is abductor pollicis longus.
Where is number 3? This one, right?
Yes.
Abductor pollicis longus. Okay.
Yeah, that comes in extensor compartment, no?
Yes. Okay. I think,
My answer is correct.
which one, brother? 8. Yes, you're absolutely correct.
Flexor carpi radialis, flexor carpi ulnaris.
You're absolutely correct. Okay. Tell me what is number 11? This one.
11.
Though they won't ask this question because it's the deep muscle and you can see.
Deep muscle flex FDP.
Now come to this portion. What is number 2?
Lister tubercle.
Okay, so what is the importance of the Lister tubercle?
This is the lighthouse of humerus. Sorry, lighthouse of radius. Because of extensor pollicis longus tendon attached surrounded to it.
Okay, so guys, Dr. Bubli, are you there? Dr. Bubli?
Yes, ma'am.
Okay, how are you?
Yeah, I'm okay.
Okay, sister, could you tell me which picture is this? Which picture is this?
It's the right hand.
Okay, this one is right hand, right? So why you are saying this one is the right hand?
Because
I would like to hear only one point from you that would that's why
Mr. Tubercle.
exactly only one is the listed tubercle. So you don't need to mention any other thing until and unless they will wait to hear the listed tubercle. So it is the flexure aspect or the extensor aspect?
extensor.
Extensor aspect. So could you tell me the carpal muscle of the hand? Carpal,
Carpal bones.
muscle.
sorry,
Carpal bones.
carpal bones. Carpal.
Okay. Okay. 12 is scaphoid. Should I tell it according to the bones or picture or?
I think I don't have the pictures here very properly. Sorry guys, I didn't correct the picture. Just say about
Okay,
the.
I can name them: scaphoid, lunate, trichostrum, pisiform, trapezium, trapezoid, capital, and hamate.
Okay, so what about the flexor retinaculum?
How the structure passes through the flexor retinaculum?
Yes, what are the structures that passes through the flexor retinaculum?
4 tendon of flexor digitorum superficialis, 4 tendon of flexor digitorum profundus, and flexor pollicis truncus, and flexor carpi radialis and median.
Okay, what is the clinical importance of scaphoid bone?
Okay, scaphoid is supplied by distal and lateral branch of the radial nerve, maximally in the distal and medial portion, and the proximal portion is neglected. So, in case of scaphoid fracture, there will be more chance of avascular necrosis.
Okay, that's excellent. So what are the bones that attach the flexor retinaculum medially? Could you tell me?
Yes, pisiform and foot of the hamate,
Okay, and the lateral bones?
scaphoid and trapezium.
Okay, so could you tell me how the Allen test is performed?
Yes, first I have to ask the patient to elevate the hand and make a fist, and then I will occlude the both ulnar artery and radial artery, and I will ask the patient to open the fist, and the hand should be branched, and after releasing the pressure, color should be returned within 7 seconds.
Okay, that's great. Excellent performance. So could you tell me what is the how would you examine the flexor digitorum superficialis and flexor digitorum profundus? At first, the superficialis.
Okay. In case of examining flexor digitorum superficialis, I have to ask the patient. I have to immobilize the proximal interphalangeal joint of the finger and ask the patient to bend the forefinger.
Okay.
Sorry, this is FDP.
Opposite.
This is FDP. This is FDP. And in case of flexor digitorum superficialis, I will fix the other 2 fingers and ask the patient to bend the middle finger.
Okay, basically adjusted fingers must be held in extension, right? In order to eliminate the flexor digitorum profundus in adjacent fingers.
Yes.
Right. So just for the flexor digitorum profundus, just fix the proximal interphalangeal joint. That's all, and ask the patient to
Yes.
bend the fingers. Right. So could you tell me where is the insertion of the flexor digitorum superficialis?
Yes, the middle phalanx, base of the middle phalanx.
The, is it the base or the sides of the middle phalanx?
Sorry, both sides.
Exactly. So this tendon splits and attaches in the side, right? So could you tell me
Yes.
what is the insertion of the flexor digitorum profundus?
Distal phalanx, base of the distal phalanx.
Okay. So wait for a while. I'm just Okay, tell me what is this? What is this?
This is intertendinous connection.
So now tell me the function of the intertendinous connection.
Okay, it creates a space between the tendons, and it redistributes force between the extensor tendon, and it also stabilizes the MCP joint and helps in extension.
Okay, that's great. That means establish the metacarpophalangeal joint and create some space between the extensor tendons and
Yes.
reach force between the tendons, right? And coordinates of the
Yes,
extensor of the tendons, right? So could you tell me what is this portion? What is this?
This is
Dorsal digital expansion.
Exactly, right. Exactly. Digital expansion. So could you tell me the which muscle that enters into the dorsal digital expansion? Or
extensor indicis and extensor digitorum.
is it the indices inserts here?
Medial.
Okay.
Number 2.
Just say the extensor expansion of the medial distal phalanx of the second, third, fourth, and fifth fingers, right? Extensor digitorum. Only the extensor digitorum. Okay. So could you tell me about the anatomical snap box?
Yes, about the boundary.
Yes, about the boundaries and the content.
Okay. And anteriorly, it will be formed by the abductor pollicis longus and extensor pollicis brevis, and posteriorly, it will formed by the extensor pollicis longus. And the floor is formed by the scaphoid and lumen, and the content is radial artery, and is the distal of the snap and base.
Content the radial artery cephalic vein and superficial branch of ulnar nerve, right? So, Dr. Tanvi, are you there? Dr. Orthopedician.
Yeah. Yes.
Okay, could you tell me the
Sorry, I have a question. Sorry.
Sure.
Can you repeat here what are the content?
Content is the radial artery and cephalic vein, right? Cephalic vein origins here. You can okay, and superficial branch of the ulnar nerve. So, Dr. Tanvi, can you tell me what is the insertion of the extensor pollicis longus?
Yes.
Just tell me
Extensor.
the insertion extensor pollicis longus.
Yes. It is the distal phalanx of thumb.
Terminal phalanx of the thumb. Very good. Base of the terminal phalanx, right?
Yes.
Insertion of the extensor pollicis brevis.
First proximal phalanx base.
Okay.
Dorsal surface.
Okay. So that is the dorsal of the base of the proximal phalanx of the thumb, right?
Yes.
Now tell me. Okay. Tell me why you are doing power grip of a hand. What is the role of the radial nerve? When you are doing the power grip of a hand, what is the role of the radial nerve? What is the role of the radial nerve? So in another way,
Dr. Lisa, can you repeat the question, please?
when you are doing the power grip of your hand, what is the role of the radial nerve? During the power grip, how radial nerve will help you?
Power grip. Okay.
Power grip.
So in another way, which
Yes.
hand grip is powerful in extension than why hand grip is powerful in extension than flexion position?
Would I tell?
I just wait for a while to Dr. Tanvi Bhai.
Riaz may continue.
Okay, Dr. Riaz.
It acts as a synergistic effect during extension.
Give mechanical force during synergistic activity.
G.
Uh, I heard new voice. Which one? Who is this?
Hello,
Who is
this
this?
is 9.
Okay, okay, bye. Okay, bye. So basically, so would you tell me the answer again so that I can get you?
It provide mechanical advantage by synergistic activity. That's why power grid is more in the
Basically,
extensor.
I heard this type of word like synergistic or anything. Basically, don't accept this type of word. So basically,
Okay.
the flexor muscles in extension position in a state of tension, right? When you are doing in extension position of your wrist joint, all the flexor muscles become in a tension, right?
Yes.
Right.
So, so when these are contract, the grip is become so powerful. It's the simplest answer. But you, when you are flexing your wrist joint and you would like to grab anything so powerfully that won't get that much force, but in extension of your wrist joint, when you like to hold anything, that becomes so powerful because all the flexor muscles become remains in a state of tension. That's why, and all the extensor muscles of the forearm is supplied by
Radial nerve.
Radial nerve.
Okay, so I think we have covered almost every single questions, almost all the questions that used to ask in your exam, almost maximum questions. Okay, Dr. Sharmin, could you tell me what is RPLC?
If there is a paralysis to the lower trunk of the brachial plexus, it causes, upper trunk of the brachial plexus, it causes the RPLC.
So what are the clinical features?
So if there is paralysis in the upper trunk of the brachial plexus, there will be some motor and sensory defect. The motor defect will be due to loss of the median nerve, and it will cause, not median nerve, like
Axillary.
yeah, in the arm it will be adducted, and due to loss of function of that adductor muscles, and the arm will be adducted and internally rotated, and forearm or elbow will be extended and pronated, and the wrist joint will be in flexion position. And sensory supply, there will be loss of the radial surface of the arm and forearm.
Exactly, it is about the arm form. So whenever they ask you about the motor affection or the sensory affection, don't try to dissect the whole thing because
Yeah,
they don't have any
it
time.
is very difficult to, we understand, but very difficult to present, the muscles, these muscles will go, so it will happen at that time. So how
So
to present this one? Only the,
let's say about
yes,
the motor affection and what are the features, what is deformity and the sensory affections. Don't try to dissect this portion because they don't have any time and they are not looking for this which nerve is involved, which muscle is involved. If the muscle is in, they ask about the muscles, I think you will able to answer all the whole thing if you think enough regarding this portion. But don't try to dissect this portion because you will, these things are really clumsy, and I think it's not needed in exam.
okay, thank you, doctor.
So, Dr. Bubli, are you there? Could you tell me about the Klumpy's paralysis?
Yes, dear. There will be paralysis of the lower trunk of brachial plexus, that will be CHT1, and there will be paralysis of the all intrinsic muscle of the hand, and paralysis of the wrist flexor, and there will be hyperextension of the metacarpopharyngeal joint and flexion of the interpharyngeal joint. These all are the motor, and the sensory loss would be the loss of sensation, the medial side of the forearm and hand.
Okay, could you tell me the what are the branches that arises from the medial cord of the brachial plexus?
Okay, medial cord, there will be medial medial pectoral nerve, medial of the medial nerve, and
Okay, that's the easiest: medial pectoral nerve, medial cutis nerve of the arm, and medial cutis nerve of the forearm, right?
yes,
Could you tell me the
of the
nerve
arm and forearm.
pectoris major?
Yeah, Bhaiya, petrous method is supplied by the petrous method.
Yes, yes, sister.
Lateral pectoral nerve.
Pectoral nerve, medial
Pectoral
and
nerve,
lateral.
medial and lateral pectoral
Lateral
nerves.
pectoral nerve.
Medial and lateral pectoral nerve.
And lateral pectoral nerve originates from the lateral cord of the brachial plexus, and medial pectoral nerve
Plexus.
medial cord of the brachial plexus. Right?
Yes.
Okay. Okay, doctor. Just wait for a while. I am looking for a few more questions. Okay. Could you tell me the function of the lumbricus, Dr. Bubli?
Yes, Bhaiya, lumbricals will do the flexion of the metatarsophalangeal joint and extension of the interphalangeal joint.
Okay, that's great. Very good. Okay, Dr. Tanvir bhai, are you there?
Yes.
Okay, could you tell me
Yes,
about
Rifat.
outlet syndrome?
Yes.
Thoracic outlet syndrome? Could you tell me about?
Yes, thoracic outlet syndrome is a neurovascular syndrome due to compression of the neurovascular structure in case of scalenus anterior and scalenus medius, involving the subclavian artery and lower trunk of brachial plexus.
And most commonly occurs due to this cause?
Most commonly cause is the scalenus anterior syndrome, that is hypertrophy scalenus anterior, scalenus anterior and medius, and cervical rib. There is a rib in the cervical 7. And another cause is Penrose tumor, unlikely.
Right. Could you tell me about the subclavian steal syndrome?
Yes. This is a neurovascular syndrome when there is obstruction of the subclavian artery before origin of the vertebral artery, and when a man rise or overactive his arm, there is a run out of the blood from the vertebral artery to compensate the proximal obstruction of the subclavian artery proximal to vertebral artery, and there is some dizziness, and this is a subclavian steal syndrome.
Why dizziness occurs really in this condition?
Yes.
So why dizziness occurs here basically?
Due to obstruction or thrombosis in the proximal part of the subclavian artery before origin of the vertebral artery.
Yes.
When a person work hard with his corresponding hand, there is decreased flow from the head neck through the vertebral artery. So patient get dizzy.
Retrograde flow of blood.
There's the only word.
Yes, retrograde flow.
I was waiting to hear the only word. Until and unless the retrograde flow, I think the answer is incomplete. So in my
Okay.
experience,
Actually, I described, but
yes, you described perfectly. You described perfectly because but the retrograde flow
part fail.
improved a lot. Could you tell me about the axillary and axillary nerve supplies which muscle? Could you tell me? Bhaiya, could you tell me?
Two muscle.
Two muscles. Please continue.
Deltoid muscle and teres minor.
Right. Okay, Bhaiya, could you tell me about the coracoid process? I wanted to ask you this question. Could you tell me all the attachment of the coracoid process? What are the ligaments and what are the muscles and the origin and insertion?
So ligaments are coracoclavicular, coracoacromial, and coracohumeral.
Exactly. Very good. So what are the
and muscles are origin of coracobrachialis and short head of biceps, and insertion for pectoralis minor.
That's great, doctor. That's great. Excellent. So I think we have covered every single questions. Could you tell me what is root value of the biceps reflex? Root value?
C5.
C5 and
C5 and 6.
And the
C6. Mainly C5.
and triceps?
C7.
C8.
Tricep C7.
7 and C8, and mainly C7. Could you tell me the abduction of the shoulder joint in every single angle?
So initiation of abduction is done by supraspinatus muscle, that is 0 to 15 degrees. From 15 to 90 degrees, it is done by deltoid muscle. And from 90 degrees to overhead, it goes with trapezius
And
muscle,
serratus
which
anterior.
rotates the scapula with the help of serratus anterior.
Okay, that's great. That's great. I have so many questions to ask. Your performance is really good, and really good. I would like to ask you one more question. One is, could you tell me about the forearm muscle of the flexor group, and what are the muscles? Could you tell me what are the superficial muscles of the flexor group, and what are the deep muscles of the flexor group?
Would I tell? Hello.
Sure.
So in superficial 5 muscle, 2P pronator and palmaris longus, and flexocarpi ulnaris, flexocarpi radialis,
Okay.
and flexor are deep.
Flexor superficial is also. Flexor superficial is also. Yes, 5 and 3.
5. And in deep, 3 muscle, flexor pollicis longus, flexor digitorum longus, flexor digitorum profundus, and pronator quadratus.
Okay. Flexor digitorum profundus, flexor pollicis longus, and pronator quadratus.
Pronator quadratus.
At the deep muscles, and nerve supply of this muscle.
All muscles are supplied by median nerve, motor branch, anterior-interosseous nerve, except flexor carpi ulnaris and medial half of the flexor.
Is it
FDP?
Yes.
FDP, flexor digitorum profundus, medial half by ulnar nerve, and flexor pollicis ulnaris also supplied by ulnar nerve.
Excellent. So I think you are all prepared. I have so many questions to ask you, like forearm from and also from hand. But guys, due to time constraint, because we have so many things to revise, we have already consumed 1.5 hours, 1 hour and 20 minutes, I think. But always remember, maximum questions from the upper limb are from the hand and the sometimes in the forearm. And if you find in your exam, basically the questions from the extensor aspect of the forearm, always start your revision with the hand when you are going to revise the upper limb. Always start your preparation with the hand, because hand is the most important thing, and forearm, and especially I don't know why people don't go through the extensor aspect, because it's difficult, but you will have to face questions from the forearm and especially from the extensor aspect. And in our real life, in our medical life, from everywhere we ignore the extensor aspect, but questions from the extensor really comes in exam, and they will ask you so many questions regarding the extensor aspect. So revise the hand and the forearm extensor aspect and shoulder also, but maximum question you'll get from the upper limb is from the hand and the extensor aspect of the forearm. So start your preparation with the hand and extensor aspect. So that's all for the anatomy portion. Now come to the history taking portion. So who was for the first session? Who was for the first session? So what was our first session?
Dr. Ifat, I have a question.
Sure.
Is there any question regarding or